We are going to be talking about mechanical circulatory devices, kind of 101 for the rehab specialist. My name is Angie Henning. I am a physical therapist. I'm a board certified cardiovascular and pulmonary specialist. I spent about 10 and a half years working at an inpatient hospital and as the team lead on a cardiovascular service line working with ECMO patients and patients on mechanical circulatory support. You see the objectives that we have here for the lecture, just basically to learn about MCS devices and the therapist's role with working with these devices. We'll start off just identifying what our typical MCS devices are that therapists will be working with in the hospital. Then we'll go into those in detail. We may have the intra-aortic balloon pump or the IABP, the different type of ventricular assisted devices, the VADs, whether they're temporary devices like the Impella, or devices like LVADs, RVADs, BiVADs, biventricular devices that can be temporary or more bridge to home and destination. We have extracorporeal membrane oxygenation, or ECMO, which got a lot of attention during the COVID pandemic. We also have extracorporeal life support, which is ECMO, which is ECLS. And we have the total artificial heart, the TAH. ECLS is not used so much. There's lots of different research on there about its viability and its sustainability. So we'll spend more time talking about the other devices. The goal of MCS devices use can vary. Like we said, the temporary devices could be bridge to recovery, bridge to a long-term device, bridge to a heart or lung transplant, bridge to a decision. So if many of our patients come in, they're really, really sick, they can be put on a device just kind of to temporarily save their device. Family may be brought in until a decision can be made if they are able to save the patient, or until a plan can be made if they're even viable or not, or until family can come to terms with making a decision to withdraw care on their family members. Sometimes, unfortunately, whenever these devices are put in place, we have a bridge to nowhere. We have some of those patients that they are awake, they're alert, they're with it. We don't see any they're not necessarily candidates for transplant, but the patients and their family are not willing to withdraw life support. So maybe we have that bridge to nowhere. And then for long term, we have that bridge to destination. So we can see that with these devices, there can be a lot of ethical decision making that's involved with the patients, with the medical team, and then what is the therapist's role in that situation can vary. And it's a discussion that continues to be had in a lot of different places. Starting with the intra-aortic balloon pump, if we look back to what that was, we think about it in school, we just kind of touch on it. That is a catheter that is inserted via an artery, typically femoral, axillary, subclavian. It goes through those arteries into the heart and sits in the aortic arch. It is temporary. There is a balloon tip on the end of that catheter. That balloon tip, it inflates with diastole, the diastolic phase of the heart rhythm, and deflates with systole. The purpose of this inflation and deflation is to help the heart to actually pump blood, to perfuse blood to the organs, as well as to actually help with cardiac perfusion. So if someone is having myocardial infarction and the heart itself is not getting perfusion, we can actually help the heart to perfuse itself. So with that, we improve myocardial perfusion to decrease the oxygen demand on the heart so that the heart is not overworking itself. We decrease that overload on the heart. So thinking about that, some of the indications that the medical team may be using for intra-aortic balloon pump may be cardiogenic shock, heart failure, and acute MI. It may be used during procedures like an angioplasty or during a stent placement. Oftentimes you may see someone come into the ICU after having had a heart bypass surgery or after having some other type of surgical procedure, cardiac procedure, when they were on cardiac bypass during that procedure, but they were unable to come off bypass. So they are on the balloon pump to help stabilize the patient, their heart function, until they either recover some heart function and they're able to be weaned off bypass. So this is a bridge to recovery or to a longer term device. Like we said, this placement can be femoral or it could be axillary, and I'm going to add in there with axillary, it could be subclavian. Traditionally, there have been some different approaches with therapy and mobility depending on the placement approach. Traditionally, patients who have a femoral approach to the placement of the IBP have been on strict bed rest. So with that, you've been limiting ipsilateral hip and knee flexion to 0 degrees pretty much. No restrictions to bilateral upper extremities or to the contralateral lower extremity. A lot of times these patients get really tight in their quad, so you may find that you're helping to the patient to roll to their opposite side, and you may have them flex their knees so that they could stretch their quad out. You may be lowering the foot of the bed so that they could do some short arc quads, some ankle pumps. We have put the bed bike over supine cycle over top of the bed and been able to do some upper extremity range of motion. Some things to look out for are signs and symptoms of compartment syndrome. A lot of times patients can have some neurovascular compromise from the femoral placement. So you might find coolness, swelling, loss of pulses distally, and therapists might be the first ones to see that. And if we can let the team know that, nurses know that, then they can take whatever approach or whatever measures they need to relieve that. Oftentimes it might be that they need to do a fasciotomy. So then therapy might be involved with some splinting afterwards to maintain ankle range of motion afterwards. I say that has been traditional because we are starting to see research, poster presentations, platform presentations, looking at patients with femoral placement of their balloon pump where they are they're doing some walking, they're doing some standing. Either they have managed to get up from the side of the bed, or they're on a tilt table and they stand them from a tilt table and then they walk. But you're seeing more of those procedures and more of that research being done. You have seen a lot of times that if say a patient was going to be listed for transplant, then the surgeons use an axillary approach to place in the balloon pump so that you could promote out of bed activity and ambulation and keeping the patient's strength up. We did want to limit ipsilateral shoulder flexion. We do still see some of that neurovascular compromise with this. We tend to see a lot of numbness, tingling, weakness in the side where the balloon pump is placed, if it's placed in the upper extremity. Some of the things that we're wanting to watch during therapy is the mean arterial pressure, the heart rate, and on the balloon pump monitor. And you will see these displayed on the balloon pump monitor. You see the blood pressure, systolic, diastolic, and the mean. You see the heart rate, and then you will see a measure. It's like 1 to 1 or 1 to 2. That is a measure of how much the balloon pump is helping, if it's inflating or deflating with every cardiac cycle or not with the patient. And of course, if we're exercising, we're monitoring for any signs of intolerance to exercise. Then we move on to our ventricular assistive devices, the VAD. The VAD is a mechanical pump that assists the heart in pumping blood, and it also improves cardiac output because it improves the ejection fraction is what it does. We have a couple of temporary devices. We have the Impella, and there are actually more than just the two that I have listed. There's the Impella 2.5, the Impella CP, the Impella 5.0, the LD, which is a left direct, the Impella RP, which is a right heart pump, and the Impella 5.5. And all of these have been they're in different clinical trials, looking at helping the left heart. The RP, the right pump, helps the right heart to pump. And again, these are temporary VADs that are used to help with increasing blood flow to perfuse to the organs. We also have larger devices that can be used as bridge to device, bridge to transplant, bridge to destination, or bridge to recovery. The HeartMate 2, the HeartMate 3, and the HeartWare. We will talk, the only one of these devices that is being implanted right now in the US is the HeartMate 3. However, you may see some of these legacy devices, the HeartMate 2 and the HeartWare, still in some of your patients. Looking back at the Impellas, like we said, are devices that may be utilized to assist during stenting, during a PCI. They may also be used after cardiogenic shock. They typically have a better outcome and lower mortality if they're used at lower flow rates, so less than 1 liter per minute for helping to support cardiac output. They do direct blood from the left ventricle to the aorta, similar to how a more permanent VAD works. We can have cannulations, again, similar to the balloon pump by femoral, axillary, or subclavian artery. We do tend to prefer, if you're a therapist, you really like that axillary or subclavian approach for cannulation, because it allows for being able to be more active for ambulation and for therapy and for exercises. We are, again, as I said, with the balloon pump, seeing patients with more severe range of motion restrictions and weaknesses after transplant if they were using these devices as a bridge to transplant. Your traditional LVAD or VAD, your ventricular assisted device, has a couple of different components. You'll see you have a drive line, which is piercing the abdominal wall, and it pierces the abdominal wall and comes from the abdominal wall externally to a controller. The controller, we like to say, it is like the nervous system of the body. You have a pump. The pump is more like the brains that's working the body, working the pump. You have an inflow graft where the blood is pulled from the left ventricle into the pump. This is inside the body. The pump is inside the body. From the pump, you have an outflow graft that goes to the aorta. And so this pump is helping to make up a difference in a low ejection fraction of the heart. And then you have 2 external batteries, and you can have a variety of accessories that are used for carrying the controller and for carrying the batteries. As we said previously, the next couple of slides are going to go more into detail again of what those different things are, components. The pump moves the blood from your heart to other parts of your body. It's implanted at the base of your heart, as we said, at the base of the left ventricle. The controller operates the pump and makes sure it's working correctly. If we disconnect some of our batteries, or if for some reason the pump is malfunctioning, there are different alarms, lights, words, warning lights that go off and let you know that something's going on. And there are typically different sounds and pitches of these alarms to let you know the severity of what is wrong, so that you can take appropriate action. That drive line connects the controller, as we said, to the pump through the abdominal wall. That drive line actually, if we look back at it, the drive line actually has several different electrical wires inside of it. And those electrical wires, again, those are like that nervous system that we don't want those to get disrupted. And then our battery is used to power the controller and the pump. And we always have two batteries, and an AC adapter and DC adapter always are required. So we're always going to be, at some point in time, we're always going to be plugging our VAD into wall power at some point to let it charge. And we want to get in the habit that if we're teaching our patients or if we're helping to switch our patients' power sources, to never disconnect both power sources at one time. So again, a closer up picture that you can see of the controller, the pump, and the two batteries, and then again, seeing the drive line going into the body, the pump, the inflow graft, and the outflow graft there. This is an example of the HeartMate 2 on a real patient. The HeartMate 2 and the HeartMate 3 look identical. They are just, for the HeartMate 2, the controller has more of a white body with a gray face. The HeartMate 3 has more of a gray body with a white face on the controller. This is an example of like a crossbody satchel that can be used. You see the crossbody satchel here. You can see that the patient has the drive line in the bottom right picture where I've indicated with the pointer. Drive line exits their body. The drive line is always reinforced with tegaderm. There is a connection piece to help so that it extends the length of the drive line so that it won't get pulled, and we don't want to pull on the driveline site. If we pull on the driveline site, that can essentially waller a hole that can be a source of infection, and that is a large reason for our hospitalization for our LVAD patients, our driveline infections. Then the controller sits into its own little pocket in the satchel. The batteries sit in their own pockets in the satchel as well. The hardware device, or the HVAD, is another one of our LVADs. It is a square box. It also has a drive line just like the HeartMate devices did. It has a different pump, but again, that pump also sits at the base of the left ventricle. It has a similar inflow and outflow graft that works similarly as pulling blood from the left ventricle and then pushing the blood to the aorta. And you also have two battery power sources as well. This is what a satchel looks like that you might wear, a patient might wear. You can see the controller looks much different and the batteries are smaller. You have a different device that you can see at the bedside for monitoring flows and numbers. Looking a little bit at what the controller looks like for patients, the drive line comes out on the right side. It's our connection here. And with that connection, it's the driveline connection at number 3 that I'm highlighting with my orange right here at the top right. We have number 1 is our top left connection. We were UK blue, so we always caused it blue stays at UK. So this connection cord is actually capped at home. That is a cord, a monitor that is attached to a monitor that stays at the bedside, and the patients don't actually have that at home. It's a monitor that's used in the hospital just so that nurses can more easily see the numbers from outside. Your two battery sources are going to be this bottom left cord and your bottom right cord, and then you see the face where you can see your numbers, your parameters on the patient's controller. Some things that we want to think out that are some LVAD precautions. Typically, when the patient has a VAD implanted, they typically have sternal precautions for about 6 to 8 weeks. Now, we know sternal precautions vary by facility, by physician, and they may be, no upper extremity movement over 90 degrees, overhead flexion. They may be only unilateral shoulder flexion over 90 degrees. They may be no lifting more than 5 pounds, no lifting more than 10 pounds, no lifting more than 20 pounds. It may be 6 weeks, it may be 8 weeks, it may be 4 weeks. It could be moving the tube. It could be that you have more of a patient-specific graduated approach to reinstating lifting based on patient-specific characteristics related to if they've had prior sternotomies, their bone density, their weight, those sorts of things. That's something you're going to be talking about with your surgeons and with your cardiothoracic team, but just know that there are lots of different, there's different literature out there about sternal precautions. And like I said, I would definitely look at articles about moving the tube and then about lifting after sternal precautions and about a graduated return to movement. One of the things that you do want to look at, and we want to make sure that we do with all of our LVAD patients, is we want to make sure that we're securing all parts whenever they're up and moving. So we make sure that whenever the patient is up, that we have a strap, we should have a strap here around their waist that prevents the VAD from swinging out away from them should they bend over. And they should have a strap that goes like a crossbody across to prevent it from dropping down. I'll answer questions at the end. We'll have time. We want to monitor vital signs, and we want to monitoring tolerance to activity, such as dyspnea scales and rating of perceived exertion. And we also want to consider that a lot of our LVADs are non-pulsatile. And so with them being non-pulsatile, thinking that our blood pressures might not be completely accurate, and our pulse oximetry ratings might not be accurate as well. And so to get a good blood pressure reading, our nurses are likely Dopplering a blood pressure. And if we want to get a good blood pressure reading, we might want to train ourselves in Doppling blood pressures as well. We want to teach our patients about battery life. And the typical battery life for the different LVADs are that for the HeartMate 2, it's about 12 to 16 hours per pair. For the HeartMate 3, it's 16 to 21 hours per pair, and for the HeartWare, it's 8 to 12 hours per pair. You must have a power source, and again, we only want to disconnect one side, one battery at a time. This is particularly vital for the HeartWare or the HVAD. The HVAD does not have an internal backup battery. The HeartMate does have an internal backup battery. It will keep moving. It will keep pumping for 15 minutes if it's disconnected. The HeartWare, the HVAD, does not. So once it's disconnected, power will stop. And if the patient is VAD dependent, then their heart will stop, and it will be a code situation. Whenever power is disconnected, even if it's one power source, an alarm will sound. Typically, whenever you get to low battery, there's a low battery alarm that sounds too on the LVAD. Battery lifespan is typically about 3 years if they're staying charged like they should be. A lot of times therapists, both physical and occupational therapists, are starting to be involved in the pre-VAD workup process. So with that, they may be involved in frailty testing. They may be involved in health literacy testing. So for our facility where I was involved, we were involved for physical therapy in doing a 6-minute walk test and the short physical performance battery, looking at gait speed, aerobic capacity, and fall risk. And particularly, we did these 2 tests because we could see a big difference if their gait speed varied a lot between 6-minute walk tests, but not during the 4-meter aspect of the short physical performance battery, then that if they were fast, had a normal gait speed with the 4-meter aspect of the short physical performance battery, but they were slow during the 6-minute walk test, then that could show us that their gait speed by the 4-meter test was good, but they were limited in the endurance test. So potentially they would likely improve with a VAD. And so because it was a cardiovascular limiting factor. We would do a lot of pre-VAD education on sternal precautions, activity expectations after surgery, exercises to prehab people and to maintain strength in that setting of heart failure. And then our OTs would do a MOCA, so a cognition assessment, and then they would do the REALM, looking at health literacy, and they would really look at their gross motor and their fine motor capabilities, so that we're looking at their ability to be able to manipulate the power cords after VAD implantation. And they would even, we had, our team was great. They had they had old VADs that we had power cords kind of cut, so that we could take those in, and our OTs could demo units that our OTs could have our patients practicing with those and putting and fastening those cords and taking them on and off. So that's a really good thing if you can get your VAD team to help you get one of those, and then you can do some simulation with other things as well. Then our PTs and OTs were consulted during implantation for a post-surgical assessment ASAP. Some of the big things that we were doing, in addition to doing just general mobility, general rehab after any surgery, we're reinforcing VAD power source and accessory management to promote functional mobility. Our OTs were consulted at discharge to teach showering. So they would, a day or two before discharge, they would do either a shower or a mock shower before the patient would discharge, and they had specific instructions that were printed out, that they would give the patient, give their family member. They made sure requested a family member to be there with the patient for the shower and the mock shower, so that this could be done beforehand. And then again, we try to do frailty and functional testing before discharge, so we could see where we had recovered and if we were better than we were before the VAD. And then we really tried to coordinate if our patients ended up having to discharge to inpatient rehab facilities. We had a handoff form that we could send over to that inpatient rehab facility, so that they knew what we were already working on, so that they could continue that plan of care. Like I said, the LVAD showering was OT led, real or mock showering. The shower bag was provided. They had the controller and the batteries placed in the shower bag. Again, we reinforced that the shower bag had to be secured cross-body and around the waist. It could not be hung outside the shower. It could not be hung on anything in the shower. It had to remain on the patient. We really enforced that when patients are walking to, that they couldn't place their bag on the walker. Nurses tend to let them do that sometimes. We try to really enforce they had to get used to wearing, the VAD on their body and getting used to that weight distribution. And again, the driveline dressing was covered with Tegaderm. Any session needs to be terminated with severe hypotension associated with fainting, dizziness, or diaphoresis, severe intolerable dyspnea, significant chest pain or discomfort, and extreme fatigue, and a patient request to stop activity. Now, we all know we take that with a grain of salt, right? Because most of the time our patients are going to ask to stop, or frequently they're going to ask to stop, but we're doing, that encouragement. Can you continue? Why do you want to stop? Is it because of pain? Is it because of fatigue? If we stop and rest for a minute or two, are you better? And then, trying to, build that therapeutic alliance so that we can get what we want to. And we did try to, if I did a frailty testing with a patient for their workup, then I tried to keep and work with them when they had their VAD implanted. So again, we already had that therapeutic relationship built, and we could continue to work with them. And we had that, we felt like we could get more out of the patient and they could trust us better. Some things to think about. So the flow is that is that cardiac output, right? So normal flow, we'll talk about in a minute. We do want to terminate flows if they drop below 2.5 liters per minute. At our facility, that was an MCS code if those flows drop below 2.5, even if the patient was awake. If you have a symptomatic drop in blood pressure, more than 10 millimeters of mercury, if your heart rate was greater than 150 beats per minute, you want to stop a session. And of course, if you have any sustained VTAC or VFib, you want to stop a session. And this is from the DeTurk and Callahan textbook. Some treatment pearls for VAD patients. You want to teach them to always sleep on wall power. And they're going to be, we try to teach them too that if they live in a remote area, or if you're in an area, we're having thunderstorms in Kentucky today. If you're in an area where you have a lot of snowstorms, a lot of ice, a lot of thunderstorms, the VAD team is going to be contacting their power company as quick as possible to let them know that they are a medically fragile patient, so that they're put on a list to, if power is lost, to have their power restored as quick as possible. Frequently, they're going to be recommended to get a generator for that reason as well. A lot of the current generations of VADs are non-pulsatile. They are working on making pulsatile ones, but even some of those, you still don't really get that pulse. So again, you're going to be limited in your blood pressure, your heart rate oscillation, your pulse oximetry. So those numbers are not necessarily going to be accurate. So you're going to be working on correlating clinical signs and symptoms using other scales and other numbers. Really, we're wanting to look at, is the patient pink, dry, and mentating? We're looking at your rating of perceived exertion, your Borg scales. We've got that original Borg scale on the left. People don't really like it. Patients don't really like it because that's 6 to 20, and we think in a 0 to 10 world, right? So that's that scale on the right. Just so you know, whenever that original Borg scale was created, it was created to kind of correlate with a heart rate. So 6 correlated with a heart rate of 60, 20 correlated with a heart rate of 200. But you will see that 12 on the original Borg scale and 4 on the modified Borg scale do sort of correlate. So that's kind of how they match up there. So when you're looking at the actual numbers on the LVAD, you see that you can see there's the speed, the power, the flow, which is the cardiac output essentially, and the pulsatility index, or the PI. The two numbers in particular that are pretty important for therapists are the flow and the pulsatility index. The flow, like we said, kind of corresponds to cardiac output, normal cardiac output being about 4 liters a minute. The pulsatility index is really, it's a measure of how the native heart and the LVAD are working together. Normal flow for the LVAD is usually greater than 3.0. Like we said, at my facility, if it was less than 2.5, we call it a code. Normal PI, again, it's how the patient and the pump are working together. Normal PI is anywhere from about 3.5 to 8. It really shouldn't be less than 1.5, and it really shouldn't be more than 10. Anything that preloads the heart, so like a cough, a sneeze, or a Valsalva, is a PI event. And so that can be like a drop in the PI can cause it to drop, or it can cause it to go up. A lot of times we will see a PI drop or the flow drop when a patient is orthostatic. And patients respond like that. They're dizzy, they get pale, they are fatigued, and sometimes, we know that these patients are being heavily diuresed. That's how they respond with us, is they respond like they're orthostatic, and we might stand them up. We will see they complain of being dizzy. If we look at the LVAD, we'll see that their flow is dropped and we see that their PI is dropped. We sit them back down. They're down for 10 seconds. Their numbers come back up. So a PI event, like we said, is that relationship between a native heart and a pump. It's going to be too high or too low. If it's constantly happening or if it stays low and if it doesn't recover with change in position, it could be an indication that there's a clot, or it could be an indication, like we said, of low volume, that the patient's too dry. We can have a suction event, which again can happen with that clot or with the low volume. And a suction event is almost like if you put a vacuum cleaner against your hand and it sucked your hand to it, and it stayed there, your skin did. If you don't have enough volume in your left ventricle, then the pump is going to keep sucking, and essentially it will pull on the septal wall, and that can cause the right side of the heart to dilate over time. And so that can cause an issue, obviously. So you want to try, we're trying to avoid that sort of thing. But like we said, the PI and low flow and suction events can all present like orthostasis. If you sit down and the patient recovers, the numbers recover, then oftentimes the patient needs accommodation training, just like a patient would who is orthostatic. You do want to know if a patient has more than 10 PI events in an hour. That's something that the team is going to need to be knowing. We would like to tell our team if the patient had even one PI event during therapy. We would tell our nurse and we would tell our team that maybe they need less diuretic. Maybe they need TED hose, something like that. But it also may mean that, if they're thinking they're going to discharge them, maybe they don't need to discharge them yet because they're not able to, do their activity that they need to do. So, those are definitely things that we're communicating openly with the team about. Another thing is if that pump is off more than 15 minutes, a lot of times your team is going to decide that they don't restart that pump because it could be clot in the pump. And if they restarted that pump, you're going to send that pump on, that clot on elsewhere. Here's just a thing to look at on the heartware. The heartware device doesn't actually show you the PI. You have to calculate the PI. There's a little arrow that's on the right. If you hit the arrow, it will let you scroll through the different numbers. You hit the arrow once, you see the peak is a 5.4, and then you see the trough, and you subtract the trough from the peak, and like here that would be 1.4, and so they would have a PI of 1.4 right now. If you see down here on the bottom, so peak here, trough here, and then on the bottom screen here, we have 3.9 liters per minute. That's our flow for this patient. For the heart mate patient, whether it is a 2 or a 3, on the controller, there's a little square. You hit that square to scroll through to see your pulse index and your flow. And if there's a monitor in their room, you can see the pulse index and the flow. So in our top left screen, we have the patient's PI, and it correlates with the pulse index on the screen of 5.8. And in our top right screen, we have a flow of 4.8, which correlates with a flow of 4.8 on the main screen. Some general education we also have. You all see these, avoiding contact sports. We're teaching them how to self-monitor. If you're teaching exercise, high intensity interval training can be really effective in improving ejection fraction and other physiologic measures. No MRI because the metal could, pull things out. No swimming, reinforcing we can shower with modification. Careful monitoring of diet, specifically vitamin K and other things that can affect your coagulation. Avoiding therapeutic modalities like diathermy and electrical stimulation, and remembering that the patient with an LVAD can be at risk bleeding be at increased risk for bleeding, so they're at increased risk for stroke, and they should avoid static discharge that can interfere with the LVAD, and I've known it to interfere with the controller, like vacuuming, like a static when you plug in a vacuum cleaner. Then we'll move on to extracorporeal membrane oxygenation. Like we said, ECMO kind of had its heyday uh, in some of the different flu pandemics and during the most recent COVID pandemic. It's a form of life support for heart failure, for acute respiratory failure, and inability to wean from bypass. It can be used as bridge to recovery, bridge to VAD, bridge to transplant, or bridge decision. It can be awake or it can be sedated. Of course, as therapists, we would rather our patients be awake. You can have two types. You can have where blood is drained from a vein and then put back in a vein, which is typically a lung support. You can have where blood is drained from a vein and put back in an artery, which is typically heart support. Some of the major different cannulation strategies we may have from the jugular veins or the subclavian. Typically, you see that with like the Avalon cannula. You can have right atrium or central cannulation with the atrias and the ventricles. You can have femoral veins. Typically, any type of femoral cannulation used to be a contraindication for mobility. That's not the case anymore. You can have arterial cannulations, which again are like the carotids, the aortas, femoral arteries. Some different pictures of some of these different cannulation sites. We have a patient here who has an IJ Avalon cannula. We have a patient here with a central cannula, and we have a patient with two femoral cannulas here. Kind of the heyday of being able to start to mobilize patients was with the Avalon cannula. It was a dual lumen catheter cannula that would sit in the IJ. We also have now a Protect cannula, which is a dual lumen cannula. With the Avalon, there's a little bitty opening that the blood needs to, it's directed into the right atrium, and then that blood goes back into circulation. Blood is pulled from the inferior vena cava to go out into the body. Again, we saw increased research with this with the two different pandemics over the past 15, 20 years. We really, again, like our patients to be awake because we can do exercises, we can communicate with them, which decreases the risk for ICU acquired weakness and post-intensive care syndrome. Some of the numbers that we're wanting to look at for these patients are the FiO2 and the sweep. The FiO2 is a measure of how much oxygen is being placed and how much oxygen support they're getting from the ECMO circuit. The sweep is a measure of how much ventilatory support or carbon dioxide removal they're having assisted from the ECMO circuit. Typically, you can see that the FiO2 range can be from 21% to 100. 21% is room air, so if they're not getting much more support, if it's 21%, then you may hear the terminology being capped, which means they essentially turn off the gas, the oxygen to the circuit and let the patient breathe on their own. And typically, if that's happening, they're close to decannulating or taking them off of ECMO. As the FiO2 increases, the patient is having more support from the ECMO circuit. Sweep range with one circuit, we've seen from like 0 to 12 liters. With 0 liters, the patient is removing all of the carbon dioxide independently. And as the liters per minute of sweep increases, then the patient is more dependent on that circuit for ventilation. A lot of times these numbers are documented either in a nursing flow sheet or an ECMO flow sheet or perfusion flow sheet. And they're also often usually on a clipboard or a sheet at the bedside as well. There's an example of when you come into the room, how you can see it. There is usually a gauge that's attached going to an oxygen on the wall that will read, and it will say 0.2% there, and where that dial lines up here, this patient's on 100% FiO2 here. On the right, you will have a bubble inclinometer that a bubble gauge that will be turned up, and that's going to represent the sweep or how much carbon dioxide is being removed. For this one, the little dot's at 8. So the sweep is 8 liters per minute. That's how much gas is essentially being swept out of the blood. You should see, if a patient is on 100% FO2, you should see a big color change between the cannula where deoxygenated blood is coming in from the patient to the circuit and oxygenated blood is bright red going to the patient. You should see a big color change. Then whenever if it's closer to room air, if it's 21%, the colors should both be dark. If they're on 100% and there's no color change, there's something wrong with the circuit and you would want to let your nurses know. These are the examples of different oxygenators. And again, you can see that this on the right side picture, you see dark blood going into the back of this oxygenator and bright red blood coming out of it, going back to the patient. So again, an indication that this patient's on a lot of support. Just kind of what we said, ECMO controls gas exchange perfusion, stabilizes the patient, prevents further injury to help recover from the primary injury, goes to prevent lung injury from mechanical ventilator support. So when vent settings get really high, that's when your patient's going to need ECMO, is because of those high ventilator settings that could damage the lungs further. It can be used for all ages of respiratory support, and a lot of times if you're a ECMO center, you're triple certified because you treat patients of all ages. For therapists and for basically anybody who's going to be mobilizing a patient, before you mobilize somebody, you want to check your cannula sites and your sutures before and after activity. Those sutures can come undone. You can have bleeding, but you may want to make sure those sutures are really, really good in place. If the cannulas migrate even a little bit, that can cause backflow, and that can cause, if you saw that little hole where the blood's being directed into the right atrium is really, really small, if it doesn't line up specifically where it's supposed to, blood doesn't go where it's supposed to, oxygenation, it's not happening like it's supposed to, and it also can cause backflow into other organs and can cause liver and kidney damage too. So you want to make sure your sutures are where they want to be. There's going to be some type of securement device at the head. Your perfusionists, your nurses, and you are always going to be looking for a way to do it better. We have used Foley straps, we have used stockinette. We finally, during the pandemic, were using like surgical caps that had a extra strap on the outside of them, and those kind of worked really well. We've used headbands like for runners and races, and different patients like different things. You also want to check your connectors. You will see oftentimes that some of the connections that don't come factory made are reinforced with zip ties. I have seen and heard of these connections that are supposed to be made by the factories, and even if they come to the factory, that some of those have come undone. And so there's oftentimes these are reinforced to make sure that that doesn't happen. You can see different circuits. This person has 2 circuits. They have 2 circuits, and the reason this person had so many cannulas as they were on biventricular support with their ECMO circuits. When the oxygenator is on, they're on biventricular support with an oxygenator, so they're on ECMO. If the oxygenator is not on, if it's cut off and they just have the cannulas, they're on BiVAD support with no circuit. Rows of PT and OT is very similar, just like with other different devices. We're wanting to prehab, we're wanting to educate, we're looking at skin integrity and cognition, delirium management. We're looking at signs of intolerance to activity, and we're really telling the patients that, and that the doctors and the team that, because they may need to change the ECMO settings accordingly. They may need to change out the circuit. They may need to change out the oxygenator if some days they're tolerating the activity and some days they're not. You can get chug and chatter in the lines, so that the lines may actually bounce with you not touching them. And if so, that may be, again, kind of like with the low flow and the PI events and the LVAD, that may be because the patient doesn't have enough volume. And so they may need to have albumin or something like that given to them. They may need to have changes in the speed of the ECMO circuit that we don't make, but the ECMO specialists do. Sometimes patients, the cannulas are very sensitive, and patients tend to like to have a lot of thoracic extension and then their head's really straight. Otherwise, you're cutting off flow into the circuit, and that can cause some of the chugging and chattering. We really want, this is expensive treatment, so we're wanting to mobilize our patients frequently, usually at least twice a day, whether it's therapy and nursing. We're wanting them to be out of bed as much as possible, going through mobility guidelines and typical progression of activity as quick as possible. Really wanting to progress gait and standing and functional movement. We did create a screening criteria for this. Patients need to be hemodynamically stable, no active bleeding, stable flows. And so with stable flows, this is from a Chris Wells article, that with rowing in bed, or if they have a femoral cannula, if you flex their hip to 90 degrees and hold it for 10 seconds, the flow should not drop more than 1 liter from what they were before you moved. And if the flow stays stable, then they're stable to try to participate with mobility. And that would include, if they're femorally cannulated, trying to sit at the edge of the bed. If they pass this screen, then we move through mobilization. And they also had to pass a hemodynamic screen. Your hemodynamic screen is essentially the same screen that you would do for any patient on a vent. This algorithm here is based on the consensus article for mobilizing patients on mechanical ventilation. So it is basically open wounds, no open wounds, stable spines. Their RAS is between -2 and +2. They have cardiac stability. Their oxygenation is stable, and then they haven't had a major increase in vasopressors in the past 2 hours, and they're not on more than 2 vasopressors, and no vasopressor is more than 0.2. That is one of the things that is inconsistent in the literature. Our ICU attending chief came up with that so that we would still have something to have some wiggle room with. We had another vasopressor to go. And then the last thing that we'll talk about is the total artificial heart, which is from Syncardia. With the total artificial heart, it, of course, is for someone who has biventricular failure. They're not a candidate for an LVAD. There is 2 implantable ventricles, a pneumatic driveline, 2 pneumatic drivelines. They have an external driver. In the hospital, you have this companion driver. They can theoretically go home with what's called a freedom driver. If they failed the LVAD, if they failed transplant, they may get that total artificial heart to wait. This patient is typically at imminent risk of dying. It is always a bridge to transplant. Research has shown there's an 85% chance of survival. If there's a big body size mismatch, they're not candidates. This is what the total artificial heart looks like. Both ventricles are removed. They are kind of held in place with Velcro, believe it or not. The 2 ventricles together with Velcro, they are sewn surgically to the 2 atria. It's a high flow, low filling pressure system. There's no preset heart rate. The heart rate's set by how the patient moves and exercises. And then just kind of comparing what the total artificial heart and what the human heart looks like. You would typically, with both the ECMO circuit and with the total artificial heart, moving in the hospital, in the ICU, have a nurse with you, is what our policy was. And then I'll go through some questions. We talked about showering. I hope that answered your question, Kristen, about what we went through. A lot of places started teaching showering because of the rates of infection that were coming back of driveline infection. So they started really making sure that they were teaching showering, um, no scissors next to the driveline, all of that to help decrease that risk. So we would just be limiting, so for axillary balloon pump, are both shoulders limited to 90 degrees or only the ipsilateral shoulder? That's a good question. It's only the ipsilateral shoulder that's limited to 90 degrees because that would be the one that might be pulling the balloon pump where it inserts. Yes, the opposite contralateral shoulder would not be having any relationship or any movement to the balloon pump, so it would not be limited. Pulsatile. So when we say pulsatile, meaning that there is when the LVAD pumps, that there is actually a pulse that is made and that is felt. So when they are non-pulsatile, you actually cannot feel a pulse, and so you actually cannot get a normal blood pressure or a normal pulse whenever you palpate that. So to do that, they have to do a Doppler so that they can hear the pressure that way. Any other questions? I know we went a long time, but there was a lot of information there. Well, I always like doing this lecture because I felt like whenever I came to work in the cardiac ICU and came to working with this information, there wasn't a lot of information out there, and I felt like I had to find a lot of it myself and ask a lot of questions. So definitely, if you're working in the ICU, be a resource to others, ask questions a lot of your nurses and your doctors, and everyone will share a lot of information with you. By all means, if you have any questions, feel free to email me. My email addresses are on the front of the course materials. And thank you for taking time out in your lunch today to listen to me learn a little bit about mechanical circulatory support devices. Have a good day.